Assalamu alaikum. This presentation is about using scoring systems to quantify patient symptoms. We shall go through 13 different scoring systems in an attempt to quantify symptoms of 6 common pharyngeal problems. We shall go through scoring systems to quantify symptoms of pharyngeal dysphagia, including the eating assessment tool E10 and Sydney Swallow questionnaires, and then symptoms of Globus Pharyngeus using Glasgow Edinburgh throat scale, followed by Laryngo-pharyngeal Reflux symptoms quantified by two scoring systems, either the Reflux Symptom Index or the Reflux Symptom Score, and then sore throat questionnaires including the Centor score, the McIsaac modified Centor score, the FeverPAIN criteria, and the Walsh clinical predictor rules, followed by symptoms of xerostomia, the Xerostomia Inventory, and the Groningen Radiotherapy-induced Xerostomia Questionnaire, followed by the Multidisciplinary Salivary Gland Society Questionnaire for Xerostomia, and finally quantifying symptoms of drooling by the Modified Teacher's Drooling Scale. Scoring systems can be very useful in assessing the baseline severity of a condition and assessing and monitoring the progress of the condition and the response to therapy. For scoring systems to be useful, they should have a strong test-retest reliability. They should also have a high validity, including phase, content, and construct validity. They should measure symptomatic severity or the frequency or the quality of life impact of the patient or a combination. And the higher the score should be in line with higher dysfunction of the condition, with some cut-off points between patients and normal controls. It should be useful in assessing the response to treatment, and it should be good at identifying true positive and true negative cases. That is to say, the sensitivity and the specificity of the test should be high enough to reduce to the minimum the false negative and the false positive cases respectively. Starting with the first questionnaire, the eating assessment tool, EAT-10. This is a 10-item subjective dysphagia symptoms that can be filled up with a patient within minutes. The patient will go through the list of the 10 items and mark 0 if there is no problem in that in an individual question, or give 4 if there is a severe problem, or anything in between depending on the grade of the severity of his symptom. And starting with questions like if there has been any weight loss, or if there has been any interference with his social activities or abilities to go out for a meal, if there is any extra effort needed for liquids, solids, or pills, if the swallowing is painful, if there is the pleasure of the eating has been affected by the problem, or if the food stuck in the throat, or there is any cough, or if the swallowing process is stressful. The maximum score would be 4 for each question, and the maximum score for the questionnaire would therefore be 40. If the patient scores 3 or more, then there is a problem with the swallowing that need to be assessed further. The validity, reliability of the test has been checked in a large cohort of patients, and it's now established, and it only identifies patients who would require further assessment by things like video fluoroscopy or video endoscopy. Normal and healthy persons with no difficulty in swallowing would score very low, something below 3 here. But if there is a problem with the swallowing, like esophageal dysphagia or cricopharyngeal dysphagia, or voice disorders, or for example gastroesophageal reflux, or a head and neck tumor affecting the swallowing process, you would expect a much higher score. The questionnaire has been used in assessing the management for the various disorders of dysphagia, like reflux, and you can see it actually works. Before treatment and after treatment, it can show the difference with reflux, with strictures, and with Zenker's diverticulum. So the validity and the reliability of the test has been established. The other questionnaire is the Sydney Swallow questionnaire, formed of 17 questions covering different aspects of dysphagia symptoms. The patient would answer the questions using a visual analog scale of straight line of 100 millimeters length, starting with a 0 point where there is no problem at all, and 100 mark would mean maximum possible severity of this particular question. The patient would put a mark along this line, and the distance between his mark and the starting point would reflect his perception of the severity. The total count of the tests would be 1,700, and normal healthy individuals would usually score something below 200 mark, although there is no clear cut-off point, and patients who have dysphagia would have marks up to 1,700. If the patient receives treatment for his dysphagia and the score changes by about 11% down the score, this is significant. Or if the patient's symptoms deteriorate by going up 7%, that's again significant. The test reliability and validity has been established on a large cohort of patients. These are the 17 questions used in the Sydney Swallow questionnaire. The initial test was based on 19 questions. 2 of these had been omitted during the validation process and testing for reliability. These are the questions for how long does it take to eat a scoop of ice cream, and do a patient ever drools saliva during the swallowing. The other 17 questions that are left cover things like if there is any difficulty of swallowing at present, if there any difficulty with thin liquids like tea or coffee, thick liquids like milkshakes or custards, soft food like scrambled egg or mashed potatoes, hard food like steak or raw vegetables or fruits, how much difficulty with dry food like bread or biscuits, and there is any difficulty swallowing saliva, and if there is any difficulty starting a swallow, and there been any sense of food catching up in the throat, or have there been any cough or choke sensation when swallowing solids or swallowing liquids, and how long does it take to finish up the average meal. This question was omitted for the ice cream. And then when you swallow food or liquids, do you ever have anything going up the nose like nasal regurgitation, and there's any need for a double swallow during meals, and do you have ever cough up or spit out food during the meals. This question have been removed about drooling. And how do you rate the severity of the dysphagia or the swallowing difficulty at present today, and how much does your swallowing problem affect your social life, your quality of life, and enjoyment with food. We move now to scoring symptoms for Globus Pharyngeus using the Glasgow Edinburgh Throat Scale, the JETS. Several patient symptoms questionnaires have been used in the management of Globus patients. One particularly useful scale is the Glasgow Edinburgh Throat Scale, which allows the patient to grade the severity of one of the 15 different types of throat symptoms. And it shows an emerging pattern in the average patient who present with globus sensation only. Some symptoms are scored highly and others are scored quite low. And both the high and the low symptoms are of help in identifying and the follow-up of globus patients. The average globus patient would score high for frequent attempts at clearing the throat by coughing or swallowing, a sense of catarrh in the throat, or a discomfort in the throat. On the other hand, they will score very low for difficulty in swallowing, or throat closing up, or a swelling in the throat, or a sense of pain in the throat. And now, Laryngo-pharyngeal reflux symptoms using 2 scoring systems, either the reflux symptom index or the reflux symptom score. One such validated symptom scheme is the reflux symptom index, the RSI. This is a 9 items questionnaire filled up by patients. It aims at quantifying the severity of the problems on a grade from 0, where there is no problem at all, to 5, where there is a maximum possible severity of these 9 items, giving up a maximum score of 45 points. These 9 items include problems in the voice, clearing the throat, excess mucus in the throat or postnasal drip, difficulty in swallowing food, liquids or pills, coughing up after lying down or after meals, breathing difficulties or choking episodes, troublesome or annoying cough, and globus sensation, and finally either heartburn or chest pain or indigestion or sense of stomach acid coming up. So out of the maximum of 45 points, a 0 score would mean that there is no problem. Anything more than 10 may indicate a problem. 13 is the cutoff point for positive suggestion of LPR. 20 would suggest a moderate LPR and 30 a severe LPR. But 13 points would be a positive score for the reflux symptoms index. To be used at every consultation, the initial and the follow-up consultations. It's fairly sensitive but has limited specificity. This is of course because other conditions of laryngeal inflammations like viral inflammations or smoking, for example, can produce a high score as well. Single symptoms like having a globus sensation would not produce a high RSI score, so you need to have several of the 9 items symptoms. On the drawback side, it considers only the severity and not the frequency of the patient's symptoms, and it not including some prevalent LPR symptoms like throat pain or dinophagia, halitosis, regurgitation, nausea, and burps, but still useful at documenting symptoms as a baseline and documenting any changes after treatment. Another validated symptom score system is the reflux symptom score, the RSS. This is a more elaborate scheme formed of 3 parts rather than the 9 questions only in the reflux symptoms index. It's formed of 22 different items plus 3 optional ones. It's formed of 3 parts. An ENT part formed of 9 different items, a respiratory part formed of 4 items, and a digestive part formed of another 9 items as well. So these 3 parts of the scheme, and there are also 3 different domains. It does not only reflect the severity of the symptoms, but also the frequency. So there is the frequency domain, the severity domain, and the impact on the quality of life domain. So 3 different parts and 3 different domains. It has excellent reliability and excellent validity, and discriminate better between patients and non-patients and the severity of the patient's problems better than the RSI. Although the two, the reflux symptom score and the RSI, correlate quite significantly at 0.8, which is highly significant. So the 22 items are divided into 3 parts, starting with the ear, nose, and throat part. Include items on hoarseness of voice, throat pain, pain during swallowing, difficulty in swallowing, clearing of the throat, sensation of a lump in the throat like a globus, and excess mucus in the throat or a postnasal drip, pressure in the ear either daytime or at night time, and burning of the tongue. There is also a space for another 1 added extra symptom by the patient not included in here. This is followed by a section on the digestive or the abdominal disorders, including heartburn, regurgitation, abdominal pain, diarrhea, constipation, indigestion, abdominal distension, halitosis, nausea, and again a question for space for another symptom to be added by the patient if needed. And finally, a chest or respiratory section, including cough after meals or on lying down, or cough during the day, or breathing difficulties, or chest pain, and the other question. So these are the 22 plus 3 different items. And the patient would score first the frequency of these symptoms, and these can be anything from 0 when the patient had not had such a complaint or each of these items in the last month, and 5 when he had it daily over the past month, and in between from 1 to 4 according to the number of episodes for each of these symptoms during a week in the last month. And after scoring each item for the frequency, the patient would score each item again for the severity. So items like hoarseness of voice or the throat pain would be scored twice, once for the frequency and the other for the severity, and the final outcome would be the multiplication of the two. You multiply the severity and the frequency score to obtain anything between 0 and 25 points for each of the 22 different items. This would total up to 550 points for the score, plus if the others questions were included, another 75 points. Now, average LPR patient would score around 112 plus or minus something around 80 points, whereas the controls would score only less than 10. So anything above 13, any score above 13 would be suggestive of LPR. The third domain is the quality of life, the impact of the symptoms of quality of life, and the LPR patients would score somewhere around 32 points, whereas the controls would be just less than 4 points. The original reflux symptom score is lengthy, formed of 22 different items that takes a long time for the patient to fill and for the practitioner to interpret. It was suggested to reduce this into a 12 items modified score, the RSS-12. This is a much shorter score formed of 12 items only. This was achieved by omitting the 3 optional questions from the original scoring system, and 4 items were also eliminated because they have not reached 50% prevalence rate, and 11 of the items were merged to form only 5 items. So we end up with 12 different items in 3 sections. The original ear, nose, and throat section is now formed out of 7 questions: hoarseness or of voice, throat pain or pain in swallowing, difficulty in swallowing, throat clearance, a sensation of something in the throat, excess mucus or postnasal drip, and a bad breath, followed by abdominal or a digestive section formed of 3 items: heartburn, stomach acid regurgitation, abdominal pain or diarrhea, and indigestion or abdominal distension. And finally, the respiratory section formed of 2 questions: coughing and breathing difficulty or wheezing. So the end up was 12 items, for again scored for severity and for frequency, and this will end up giving 300 points, maximum of 300 points. Anything more than 11 points will be suggestive of a degree of laryngo-pharyngeal reflux. The average laryngo-pharyngeal reflux scoring was actually quite close to 80, plus or minus 50, and the controls would score only less than 10 points in this modified questionnaire. Scoring systems for sore throat symptoms include the Centor score, the McIsaac modified Centor score, the FeverPAIN criteria, and the Walsh clinical prediction rules. Now let's consider this example. Say if you have 100 consecutive cases of acute sore throat. You know that roughly 25% of those 100 patients would have a group A beta hemolytic strep, and those are the patients that would require or benefit from the antibiotics. The real question is, how can you identify those 25% out of the whole lot to avoid giving the 75% and unnecessary antibiotics, and to treat the 25% who need the antibiotics? There will be some true negative cases and some true positive cases, but there will also be some false negative and some false positive cases. So there would always remain a certain degree of ambiguity in the risk stratification of those patients. Now, generally speaking, the clinical scoring systems are good at identifying the true negative cases if the scores are very low. If the scores are 0 or 1 or even 2, then it's very unlikely that those patients would have a group A beta hemolytic strep. These are the gray circles here, and they can avoid having an unnecessary treatment. The efficacy of the scoring systems is less in identifying the true positive, but it's even less in identifying the other group of patients with the yellow and red circles who are either false negative or false positive. A sensitivity test suggests that roughly using clinical scoring systems, one would miss 25 to 50% of patients who have a group A beta hemolytic strep as false negative. Those patients may have benefited from antibiotics, but the test had indicated, the scoring system had indicated that they are free. And the specificity test would say that 20 to 40% of the cases would be labeled as having a group A beta hemolytic strep with a negative throat swab or culture, that is to say a false positive. Those patients would have antibiotics unnecessary, in contrast to the red circles who would not have antibiotics when they actually need it. We'll go through 3 clinical scoring systems that are currently used for risk stratification of acute sore throat patients. The first is the Centor score, which was developed in the USA in an emergency department setting as early as 1981. It's limited to patients who are at least 15 years of age. The Centor score gives 1 point for each of the following 4 items. If there is tonsillar exudate, if there is tender anterior cervical lymph nodes, and a history of fever more than 38 degrees centigrade, and absence of cough. So the maximum possible score would be 4 if you get these 4 points together. The likelihood of having a group A beta hemolytic strep infection increases with the increasing Centor score. So if the Centor score is 0, that is to say you have not scored anything in the 4 items, the body temperature is less than 38, there is a cough, there is no cervical lymph nodes tenderness or swelling, and there is no tonsillar swelling or exudate, the score is 0, chances are less than 2.5% that there is a group A beta hemolytic strep. If you have only 1 positive item out of the 4, you score 1, the chances would increase to between 6 and 7%. 2 items, the chances would still be around 15%. 3 items, then the chances would be more than 30%, about a third of the cases would possibly have a group A, and all the 4 items, the chances are more than 50%. You are more likely than not that there is a group A beta hemolytic strep. The guidelines would advise that if the score is 3 or 4, then an antibiotic prescription should be considered. The Centor score is simple and rapid and has been endorsed by the National Clinical Guidelines, the SIGN 2010, which gave a recommendation that the Centor Clinical Prediction Score should be used to assist the decision on whether to prescribe an antibiotic or not, but cannot be relied upon for a precise diagnosis. It just helps to decide whether antibiotics are needed if the score is 3 or 4 or not. The same guidelines had suggested that using throat swabs should not be carried out routinely in the primary care management, as the clinical scoring system would provide equal information. The Centor score was also endorsed by the National Institute of Clinical Excellence guidelines, would also suggest the use of the Centor score or other clinical scoring systems to advise whether immediate antibiotic prescription should be given for patients with acute sore throats who have a score of 3 or more, when the risk of having a streptococcal infection is between 1/3 and 1/2. The Centor score can only be used for patients who are 15 years or more, and the age of the patient was not considered in the criteria of the Centor score. A modification of the Centor score by McIsaac and his colleagues had added the age of the patient to the criteria of the Centor score. So if the patient's age is between 3 and 14, you can add 1 point. If the patient age is more than 45, you subtract 1. And if the patient age is between 15 and 44, then there's a 0. You can add 0. This is taking into consideration that group A beta hemolytic strep is more prevalent in the group of patients between 5 and 15. That's why a +1 can be added to patients in this age group. The McIsaac score, the modified Centor score, is basically the 4 criteria of the Centor score: temperature above 38, no cough, cervical lymph nodes tender or swelling, and tonsillar exudate or swelling. These are the 4 items of the Centor score. To this you may add the age factor. If patients are below 15, then they would have 1 point. If the patient are more than 45 years of age, then you subtract 1 point, and between 15 and 44 you get a 0. And again, the likelihood of having a group A beta hemolytic strep increases with the increase in the score. So at a score of about 0, the chances is almost 1%. If there is at 1, if there is only 1 factor of this, the chance is about 10, and it increases gradually. The maximum score would give you a chance of about 50% that there is a group A beta hemolytic strep. Then came a third clinical scoring system, the FeverPAIN criteria, which was developed in the UK in a primary care setting in 2013 and was endorsed by the National Institute for Health and Care Excellence, which recommended the use of either the FeverPAIN or the Centor score to risk stratify patients with acute sore throat. The FeverPAIN scoring system incorporates 5-point scale with 1 point for each of the following. If there is fever, this is the fever part of the FeverPAIN scale. During the previous 24 hours before the consultation, then you get 1 point. The pain is a P for purulent on the tonsil, pus on the tonsil, and an A if the patient attend rapidly within 3 days from the onset of symptoms, if you attend consultations rapidly, and an I for an inflamed tonsils, severely inflamed tonsils, plus the pus on the tonsils, and an N for no cough or nasal congestion or drip. So this would give you the 5 points scale for the FeverPAIN criteria. Then 3 clinical decisions can be taken from there. If the score is 0 or 1, then no antibiotics are required. If the score is 2 or 3, then you can either give the patient a delayed prescription for antibiotics to use it only if symptoms gets worse or does not improve in 3 days. Around 2/3 of people who have the delayed prescription will not use it. If the score is between 4 and 5, then the patient would require immediate prescription for antibiotics. This is a quick comparison between the 3 clinical scores. Starting with the Centor, these are the 4 criteria for the Centor. The number 1 criteria is that there should be no cough, and this is repeated by the other 2 scoring systems. The FeverPAIN would add no cough or rhinitis. The other factor is history of fever. This would be repeated also with the McIsaac. It will specify that the temperature should be more than 38 degrees, and the FeverPAIN would insist that this should be in the preceding 24 hours before the examination. So these are two of the four factors. The third is tonsillar exudate. This is the same in the McIsaac and the same with the FeverPAIN. Now, the anterior cervical lymph node swelling or tenderness is also mirrored in the McIsaac, but it's not included in the FeverPAIN. The FeverPAIN, on the other hand, has two other factors. One of them is quick or rapid presentation within 3 days of the onset of the symptoms, and the other is, in addition to tonsillar exudate, there will be a severely inflamed pharynx or tonsil. On the McIsaac, there will be one added factor, that of the age, where age before 15 years would add a point, and more than 45 years you would lose 1 point. Note that with very low scores, like a 0 or a 1, both the Centor and the McIsaac would have very low chance of having a group A beta hemolytic strep. With the FeverPAIN, the probability is higher. With a FeverPAIN score of 1, the probability is about 16%. This is almost double the probability for the other two scores. Note that the FeverPAIN is actually designed to risk stratify not only group A beta hemolytic strep, but beta hemolytic strep in general, including other groups like group C and group G. Now, the maximum possible score for the three of them would give a probability of between 56% or so and 63%. This would be the maximum. So there will always be a chance of missing maybe somewhere between 40 or 50% of the patients infected with group A beta hemolytic strep, even with the highest possible score of the three different scoring systems. This is a graphic comparison between FeverPAIN and Centor score for the same group of patients. You could see a group 5 score for the FeverPAIN. This is unique because there is no group 5 for the Centor score. This is the highest possible probability of identifying the beta hemolytic strep. Otherwise, the comparisons show that they are fairly similar. With different grades, sometimes the Centor would pick up more or the FeverPAIN would pick up more. They are fairly similar, except that with a grade 5, score 5 for the FeverPAIN, this is the highest possible probability. Now, comparing the high scores of the Centor versus the high scores of the FeverPAIN in 100 consecutive cases of acute sore throat, would show that with the Centor scoring, it would identify the true negative cases, the gray ones here, in 73%. The FeverPAIN would identify 82% of the true negative cases. And the true positive, the Centor would identify 4, and the FeverPAIN would only identify 1 true positive. And then there would be false positive cases for about 11 cases in the Centor and only 2 cases in the FeverPAIN. And then the false negative cases will be 12 in the Centor and 15 in the FeverPAIN. So this is just a graphic comparison between the two scores. It would show that with the high scoring, FeverPAIN is better at identifying the true negative. The Centor scoring would be better at identifying the true positive cases. Other clinical scoring systems were also suggested, including the Walsh clinical prediction rules, which adds 1 further point for a contact between the patient and another patient who has a group A beta hemolytic strep tonsillitis. So if he's in direct contact with another patient with approved tonsillitis, he will get an extra point. There are other systems as well that incorporates the patient's own perception of his problem, like a home score for identifying the pharyngitis. A randomized controlled trial had looked into applying the suggestions of the FeverPAIN stratification of risk in prescribing antibiotics for patients with acute sore throat. So if you have a low probability with a FeverPAIN score of 0 or 1, patients will not be offered antibiotics. If there is a moderate risk with FeverPAIN score 2 or 3, then the patient will be provided with a backup prescription, not for immediate use, but to be used if his condition is not getting any better or is getting worse. And with a high risk patients with score 4 or 5, they will be given an immediate prescription for antibiotics. And the results showed that there was some improvement in the symptoms, statistically improvement, perhaps not clinically significant, but it was statistically significant. And there was also reduced antibiotic use using this strategy. About 27 to 29% less antibiotics were used. The additional use of other ways to identify patients who have a group A beta hemolytic strep, like for example rapid antigen test, was not necessary. The clinical scoring test actually showed the same amount of information gained with the application of other tests like the rapid antigen test for group A beta hemolytic strep patients. And for quantifying the symptoms of xerostomia, 3 different scoring systems, including the more general Xerostomia Inventory or the specialized scoring system for patients after radiotherapy-induced xerostomia, the Groningen Radiotherapy-induced Xerostomia Questionnaire, or the more recent scoring system including xerostomia and salivary gland disorders, the Multidisciplinary Salivary Gland Society Questionnaire. We move now to quantifying the patient's symptoms, the xerostomia or the dryness, and its impact on his quality of life. This is particularly important to assess the patient's response to management and also to see if the condition is deteriorating with time or with further management plans, including extra radiotherapy management. There are several of these. Some of them were developed for xerostomia patients in general, and some for xerostomia patients following radiotherapy treatment. One of the simplest questionnaires was the Xerostomia Inventory, which would quantify the patients of xerostomia in general by asking them some very straightforward questions, and they would have to grade it between never and very often. Basically, these are the sense of dryness in the mouth and how they attempt to alleviate it by sipping liquids, for example, or sitting up at night to drink, or having to suck sweets or candies, or if they have difficulty with eating dry food or certain types of food, or if they feel their skin of the face or their eyes or the lips or the noses are dry. The Groningen Radiotherapy-induced Xerostomia Questionnaire is quite similar. In addition to questions about the xerostomia, it also includes questions about the quality of life of patients receiving radiotherapy for head and neck cancers. Things like whether the patient have difficulties with eating due to the sticky saliva, or difficulties with talking, or difficulty with sleep, all are as important aspects of impacting his quality of life. The most recent and perhaps the most comprehensive of these scoring systems is the system suggested by the Multidisciplinary Salivary Gland Society Questionnaire in 2021, which includes 20 different questions. The first 13 questions are very similar to the last two scoring systems, but it have another section related to problems of the salivary glands itself, like if the patients feel any sense of tightness or itching in the salivary glands, or experience swelling in between meals or during the meals, or have any persistent swelling, or if they have to take antibiotics for salivary glands swelling, and if the pain is caused by this swelling need to be evaluated, or if they have any discomfort by the salivary gland swellings. So it has a separate section for salivary gland problems, in addition to the usual questions of the impact of xerostomia on the patient's quality of life, and describing his dryness, the intensity of the dryness, or the frequency, the quality of the saliva and the taste, and the impact of this on talking or chewing, or sense of dryness in the lips or the nose or the eyes. There are two ways of scoring the Multidisciplinary Salivary Gland Society Questionnaire. One of them, the Q3, is by answering the questions by choosing one of 5 different answers. The other way of scoring, the Q10, is by a visual analog scale along a line of 10 centimeters, choosing a point along that line. Both ways, the Q3 and the Q10, are very reliable, more than 90% reliability for both scoring systems. A healthy volunteer would score about 19 for the Q10, whereas patients who have xerostomia would score, the mean of the patients with xerostomia would score around 50. The developers of the McIsaac recommends using the second way of scoring, the Q10, with the visual analog scale, rather than the Q3 with the question answering. And finally, for the quantification of drooling in children, we use questionnaires filled up by parents, carers, or the teachers. We'll go through the modified teacher's drooling scale.
These are the common and the simple tools to quantify drooling. It includes methods to quantify the severity and the frequency of the drooling, and also a method to assess the response to certain treatment or intervention. The drooling rating scale evaluates the severity and the frequency of the drooling. Also, the modified teacher's drooling scale covers these two areas, the severity and the frequency of the drooling. You can just simply measure how many napkins have been changed daily for the child, and this is the basis for the BIP diary, and the drooling impact scale, which evaluates the effect of intervention on the salivary control after various forms of treatment. The second tool, the modified teacher's drooling scale, is a combination of the two areas, the frequency and the severity of the drooling, into one system, where 1 is never drools, 2 and 3 are mild drooling, and making only the lips wet, either occasionally or frequently. 4 and 5 is moderate drooling, wetting the lips and the chins, either occasionally or frequently. 6 and 7 is severe drooling, wetting the clothes, again either occasionally or frequently. And 8 and 9 are profuse drooling, wetting the clothes, the hands, the trays, and objects around, either occasionally or frequently.
By this, we come to the end of this presentation on using scoring systems to quantify common pharyngeal symptoms. Assalamu alaikum.